Hi friends. In this session, I'll be discussing about the topic acalculus cholicystitis. Uh, the acalculus cholicystitis mortality is high, right? And what do you mean by acalculus cholicystitis? Acalculus means no stone. Choli in the sense gallbladder. Cystitis. Cholecystis is a gallbladder. Itis is inflammation. So it's a blockage of cystic duct, right? Blockage of cystic duct. In absence of stones, is called acalculus cholecystitis. See, you can look into this. This is the gallbladder. This is a cystic duct. This is a common hepatic duct and common bile duct. Now, blockage of this cystic duct, okay, in absence of stones. No, there are no stones, right? Yet there is a blockage of the cystic duct, and this is known as acalculus cholecystitis. Because of the blockage, there is no passage of this biles, right? Though the accumulation happens, so there is an inflammation happening in the gallbladder. Now, what are the risk factors for the acalculus cholecystitis? Old age is a risk factor. Recovery from the major major surgery. Recovery from major surgery, it is a risk factor, right? I do understand. In the burns, right? In burns, you have the risk factor. Trauma, right? Burns, trauma, prolonged use of TPN, right? Prolonged use of TPN, critical illness because of the infection, inflammation, all the trauma, same pathophysiology, same burns, immunosuppression conditions, and diabetes mellitus, right? Diabetes mellitus. So these are the risk factors: the old age, burns, trauma, prolonged use of TPN, critical illness, immunosuppression, and diabetes mellitus. So, in these conditions, risk factors, the patient presents presentation is more of fulminant. What do you mean by fulminant? It is a dangerous, progressive, okay, than the calculus cholecystitis, and may process to a gangrenous gallbladder. Now, this is so dangerous, right? The presentation, the patient can have a gangrene here. So, it is more dangerous than a calculus cholecystitis, and this the gallbladder can go into state of gangrenous, right, because of a decreased the no blood supply. So it can go to a gangrenous gallbladder. The next important aspect, the patient may not have a right hypochondrial pain because he has an other effect, right? His body is immunosuppressed, right? So he cannot get it actually, right hypochondrial pain. The patient may not have a right hypochondrial pain. The critical ill patient with pericholecystic fluid, right? If a patient has a critical ill patient, when you examine in a scan, he has a pericholecystic fluid, he has a gallbladder wall thickness, right? That is more than 3 mm on imaging, and you should raise a suspicious of a disorder, right? You should have the suspicion that he has this ear calculus cholecystitis, right? So you're not supposed to neglect a patient who have an ill-defined patients, and if they have a pericholecystic fluid, if the gallbladder is thickened, that is more than 3 mm, 3 mm more than 10 mm, on imaging should raise a suspicion of this disorder, right? Now, the next point is HIDA scan is diagnostic but can have a false positive result. What is HIDA scan? HIDA scan is hepatobiliary immunodiacetic acid, right? Immunodiacetic acid, right? You have immunodiacetic acid. Now, what is the dye which you give to the patient after the fasting? The moment you give the dye periphery, and this dye go into the blood, and when you scan, the gallbladder uptake of the dye by the gallbladder is 90% in 30 minutes and 100% in 1 minute, in 1 hour. If a patient has a decreased uptake of the gallbladder, it means that he has some infection. He cannot uptake this. So there is an cystitis, right? Cholecystitis. In such conditions, the uptake of this dye by the gallbladder it takes around 2 hours, right? And remember that this what is the problem with the HIDA scan here? The HIDA scan gives a false positive result, right? False positive result. Now I need a patient who came with this acalculus cholecystitis, I want to put I want a treatment here. So you have a fluid, so much of fluid, you can't go with the cholecystectomy. You can remove the, you can't remove the this gallbladder cholecystectomy. So what I do is I put a percutaneous cholecystectomy. I put a tube, okay, percutaneous, okay, percutaneous. So I drain that. So when I use a percutaneous cholecystectomy, and 90% patients improve. Remember, the 90% patient improve. And if a patient have an interval cholecystectomy, right, interval cholecystectomy is necessary only if, right, interval cholecystectomy is necessary only if follow-up image shows a positive finding, right? So interval cholecystectomy is necessary only not in all the conditions, only if the follow, if the same patient have the image shows a positive, if he has this positive images in towards the acalculus cholecystitis, I do a cholecystectomy. In 90% I don't do because patient improve by percutaneous cholecystectomy, right? That's all for the acalculus cholecystectomy. Sorry, acalculus cholecystitis. Thank you.